Hello everyone, I am Mariah Taladua, and together with Miss Sheena Braga, we are going to tackle about meningococcemia. The learning objectives of this presentation are the following: discuss the nature of meningococcemia, the etiology, mode of transmission, and lastly, the signs and symptoms. Discuss the various methods of prevention and control of the Department of Health or DOH related to meningococcemia. And lastly, identify the appropriate treatment and nursing care for patients with the said disease. Meningococcemia is generated by infection with the gram-negative diplococci bacteria meningococci called Neisseria meningitidis. Blood tests, scrapings of the skin rash, and sampling of the patient's cerebrospinal fluid can all be used to identify the strains of this bacteria. An individual can be infected with direct contact with the respiratory droplets from the nose and throat of an infected person. In terms of the mode of transmission, people spread meningococcal bacteria to other people by sharing respiratory and throat secretions such as saliva or spit. However, they are not as contagious as the microorganisms that cause the common cold or the flu. Moreover, transmission through inanimate objects belonging to the patient infected is insignificant. The following are common signs and symptoms of meningococcemia: high-grade fever during the first 24 hours, weakness, joint and muscular discomfort, stiff neck, meningeal irritation such as headache, nausea, and vomiting, bulging fontanelles in babies, seizures or convulsions are the most typical symptoms. Hemorrhagic rashes are also visible, ranging in severity from a few petechiae to extensive purpura and ecchymosis. Additional symptoms include changes in the senses, such as photophobia, a condition in which the eyes become more sensitive to light. Further methods of prevention and control as embodied in the policies and standards of public health programs developed by the Department of Health. First, to prevent the exposure of this disease to the hospital staff, the infected patient should be isolated for the first 24 hours upon admission. The hospital personnel are also required to put on appropriate PPE such as mask, gloves, goggles, and gown when entering the room of the patient with meningococcemia, especially when they are doing an endotracheal incubation. Chemoprophylaxis can also be considered for people such as young children or household members in close contact with patients.
In order to reduce the risk of exposure, the general public must be trained to avoid congested areas, particularly among the young and elderly. Furthermore, even when caring for patients, hospital personnel are rarely at risk. Thus, only those with intimate exposure to nasopharyngeal secretion or unprotected exposure during endotracheal incubation require chemoprophylaxis. There is currently no meningococcemia outbreak in the Philippines, according to DOH Assistant Secretary of the Public Health Services Team, Maria Rosario Vergeri. They do, however, work very closely with their regional office on contact tracing. Individuals with direct contacts of the patients are receiving post-exposure prophylaxis and are monitored for signs and symptoms of meningococcemia. Apart from that, the DOH strongly advises everyone to exercise good personal hygiene, such as hand washing and covering one's mouth and nose when coughing or sneezing, in order to avoid the transmission of the disease.
The DOH is also considering to include the meningococcal vaccine in the national immunization programs in order to prevent the individuals from being infected by the said disease. Meningococcal polysaccharide vaccines are available as bivalent or tetravalent vaccines. These are generally safe and only cause significant systemic reactions in a small percentage of cases. It is recommended for the protection of close contacts, and after 10 to 14 days, it may provide appropriate protection. Since meningococcal outbreaks usually affect specific age groups, the immunization target population may change depending on the epidemiological circumstances.
Meningococcemia is commonly treated with penicillin or ampicillin. Adults are commonly treated with intravenous penicillin G. Although penicillin is still the preferred treatment for children, other pathogens must be eliminated before treatment can begin. For the nursing considerations of this disease, it must be remembered that the patient must be given chemoprophylaxis before being discharged to ensure that the meningococcus is no longer present in the nasopharynx. Infection control measures such as thorough handwashing with soap and water and other respiratory isolation should be followed, especially within the first 24 hours of admission. In addition, consider using gown technique, which includes masks, goggles, and gloves when performing endotracheal intubation. Furthermore, other methods of isolation to consider include not sharing utensils, cups, lipsticks, cigarettes and other water bottles, dishes and glasses, musical instruments that have mouthpieces, mouth guards, or anything else that has been in the mouth of the infected person should not be used. There must be also health education on the importance of a well-balanced diet, regular exercise, adequate sleep and rest, and abstaining from alcohol and tobacco use. And 1 week checkup must be recommended, followed by monthly checkups for those with complications until they improve, as well as contact tracing. Here are the references that we used. And that is all for the prevention and control of the disease meningococcemia. Thank you for listening.